Okay, so now we've had, I think, a very full body of information. We've heard from Brian, who shared the gloom and doom about local public health workforce, and Kalpana, who's making us feel real optimistic about what the hospitals, particularly safety net hospitals, are doing to try to advance the skill set of those individuals working in population health. And then from our discussants, where the accrediting bodies, whether it be for the schools of public health or the local health departments, are really working to try to expand the competencies to meet today's challenges in population health. And while you may not have the accrediting responsibility, sounds like at least some wonderful efforts to try to bring educational resources to the practice community. We have a few minutes for questions and answers, and I could start with one, but how about I do that so you can get ready for your questions? Okay. All right. So a couple of things that really stood out to me in the conversation this morning, and that is that the level of unpreparedness for folks who are in key decision-making positions in population health. And I was just curious about through your assessment work and your accrediting work and evaluating, because you're evaluating all of these efforts, have you come across, at least from a structural aspect, a need to really look at, when we're doing all of this training, are we targeting the right people? Especially if longevity is an issue. Are we addressing this work at the right level? So that's one. Because, and then the other one that sort of stuck out to me is this issue and concern about a supportive work environment for population health, whether you're in local government or public health. And Kalpana didn't mention this, but in their study, they indicated that, those population health officials had a real difficult time trying to situate themselves and help people understand what it is that they were doing. So it was not just making sure they had the skills, but really being able to spread the importance of the work in those institutions. So I just with those two things in mind, are we targeting the right people? And, what are we doing to assure that the environment embraces population health or embraces equity, for example, as you mentioned, Brian. So just my thoughts. And you can jump in and wherever. It's for everybody.
So I think I don't really, I've been in public health probably longer than some people in the audience are old, so I won't quantify those years. But I don't have data for this, so these are just my observations over the last 40 years. We do tend to see the same people at the same trainings in terms of some of the more innovative conferences and that kind of thing. Ron Bialik will be able to speak later to, that may not be true for the online training and the resources that are available, such as public health foundation funds. What we've observed at the Public Health Accreditation Board is what the leadership in the health department does matters. And I think that the more that we see public health department leaders, and I don't just mean directors, but that whole the whole upper echelon of the org chart, if you will. In general, what they promote, what they believe, what they emulate with their leadership and management matters. And so you get a progressive, well educated in the whole arena of managing a public health department leader who surrounds him or herself with other leaders who are interested in quality improvement. They're interested in health equity. They're interested in being innovative. Then you see that health department make an almost dramatic shift. And again, I don't have data. We are trying through our Center for Innovation to capture some of these case studies. But I guess I would say on that, leadership matters. It's always mattered, but I think we can see also when you have a health department where leadership matters and that leadership leaves, almost as dramatic a shift in lack of attention to those things. And I don't, I know there are all kinds of courses and all kinds of education targeted to public health leaders. And on some level, that seems like, well, maybe that's the wrong level because they don't have a long shelf life at the state level particularly. But on the other hand, what we see from our lens is that what happens with the leaders matter. So that's our perspective.
So I totally agree with you. It's at times I feel like many of these vice presidents of population health have to find their voice to even explain what they do and to their peers. And I also see most of these success stories comes from hospitals where the CEO and this person is heading the population health in sync and know what each other is doing. And there's a dual leadership that's needed. It's not, again, Vice President of Population Health is not a magic bullet, and that's why the CEO's support or the board support and the governance support is very important. Most of the hospitals where we find, like, let me say, Bonsaco it's not just George Klebb who's heading the population health work, it's Sam Ross who's supporting the work as a CEO. And that's important. So that doesn't come from the essential skills or the training. It comes from the peer pressure and from the environmental changes and the motivation that needs to get to the board and the CEOs.
I just want to, are we training at the right level? I spent a decade in governmental public health, and you need to have a title before we train you. You need to be a Title V director, then we'll train you. We need to be a state health official, then we'll train you. And we're not. It's kind of like, if you get to the top of the mountain, we'll train you. And, I had said this at APHA, so I'll say it again. I do think one of our challenges that you don't have in hospitals is that if the only office you've ever seen in a governmental public health department is that of the commissioner, I question whether you really have the credentials to run the organization. And I know that's a provocative statement, but let's be clear. If I was appointed the head of Toyota tomorrow, there would be an immediate stock correction. The stock would tank because they would say, what does he know about running Toyota? Oh, dear God. But I've worked in states where the commissioner came in, never having worked in government, never having worked in public health, not having an MPH, having managed a staff of 5 most of his or her career, and now is doing a staff of 1,500. And it immediately changed it. And so our approach too often, and I'll just ask you guys, if you were on the next flight you're on, if the flight attendant comes on and says, the pilot has never been trained in flying a plane, but we're going to start training them now, who stays on that plane? Then we wonder why 50% are leaving? Like, come on. Like, let's just be real about it a little bit.
So we've got a lot of questions, and please don't use me as the model. Short, and maybe we'll get to as many as possible. So I'm going to start with the left, and then we'll go right. Okay.
Hello. So I have a question for Brian. I work at American Planning Association, and your survey is amazing. We are thinking of doing a membership survey similar to what you have done to understand the workforce. So this will be really helpful. So my question is that the most staggering number is that almost 40% of workforce wants to leave. And my assumption is since they are they like what they do, they are satisfied with their work, they're moving, and they have training in public health, they're moving to other departments maybe. So my question is, have you plotted your data geographically to see which areas are in crisis and what is happening in terms of migration within geography?
So there is a question about where are you going?
Yeah.
It's a question we need to fix in 2020. because there's an other section, and most people select other, and then other becomes like a real gamish of nothing clear.
Sure.
Some are moving, some are staying in governmental public health. But when I first went to governmental public health school, or when I first went to public health school, government was something that you did. There wasn't a Federal Reserve job in public health like there is now. So we're competing with so many more sectors. And Mike, so this is WINS is done with ASTO, NACHO, and the Big Cities Health Coalition. We have regional data. We have data by state. And we're kind of working right now to figure out, one of the things that we guarantee is that the state data will not be released without permission of the state health official. And so we're talking through, could we actually look at this leaving issue, state by state? Because it definitely does distribute differently geographically. But generally, again, we need to create a real crisis around the fact that half of our workforce may not be here in a couple of years. And that's how do we get Congress to hear that, NGA, NCSL? It's just a hard argument to make when Medicaid is what's getting attention, when other things are just being prioritized.
Yeah. Thank you.
Okay, we're going to move to the right, and remember, our session is being recorded, so please state your name clearly and let us
Sure.
know your affiliation.
Good morning. Thank you for your presentations. My name is Anna Ricklin. I'm from the Fairfax County Health Department, so a local health department. I was intrigued by the data point that Brian shared about people thinking, being driven by health equity, but then not necessarily tuning in with the factors that really need to be addressing the social determinants of health and really addressing health equity. And also that folks are not super familiar still with health and all policies concept, which is actually the role I have with Fairfax County Health Department. And I've found even within our health department where we have this role, many of our staff are still not familiar with it, particularly on the clinical front. And so I'm wondering if you could comment on that. So this isn't the I'm not expecting a firm answer, but just sort of as a thinking question, what you all think to do to shift the culture to really be more aware. And I imagine that the accrediting organizations think that we just need to have more standards or to have health departments reach for, and then therefore, it's kind of like teaching to the test. But I was wondering what a couple of folks could comment on that.
We can have just two brief responses.
I'll do just a quick lead in. Why are we surprised that they don't see a role of the health department in social determinants of health? We're not funded to do it. There's no funding stream. Just because a bunch of us in DC and Atlanta decided that this was a good thing for us to do and then didn't stream any funding that way, didn't help people reorganize in that way, yet we expect them to just do it? I mean, we have a lot of folks who are just still delivering diabetes education, right? One-on-one, these kind of clinical plus services. So someone has to say that health and all policies is important and here's the training materials, yet what we tend to do is we are the best people at throwing parties and giving no directions. I'm going to have a party.
Who's the we?
Us. All of us. The DC, the Atlanta, the CDC, the ASTOs, the NACHOs, all the APHAs, the Karen DeSalvos, the Public Health 3.0s. Like Public Health 3.0 is brilliant. I love Public Health 3.0. But it's like, here's a great thing and you should get here. And you say, well, how do I get to the party? Like, we're not going to tell you. We're not going to provide training. We're not going to provide transportation to get you to the party. So again, we throw a lot of frameworks out there, but very little path to get there. That's where, again, I think FAB comes in as one of the few mechanisms we have to say, this is how we move the field to where we think it should be.
Again, I'm publicly agreeing with the Brian. But I also want to go back to something Kevin said earlier when Kevin talked about categorical program bias. And so Kevin, I'm going to be quoting that because I think that we talk about de-silifying. That's the phrase that Les Beich on our board came up with. But I think the categorical program bias is much more descriptive of what happens in health departments where it's all about what I'm doing and what, and I have to be fair, with the cuts that the health departments have had, a lot of our health department staff are doing well to do what they're doing, right, in their categorical programs. So I do think we have to shift the categorical program bias. And I do think we have to make it more expeditious for our frontline workers to relate social determinants, health equity to to whatever they're being paid to do at the health department.
So we move to the left, Ron.
Good morning. Ron Bialik with the Public Health Foundation. And I'm going to publicly agree with Brian and Kay as well about these broad assessments. There's a lot that's already been learned. Then the question I have is, when you take a large category like budgeting and management, for instance, and now you drill down to the agency, there's a lot under budgeting and management. So what thoughts do you have about getting deeper into what is it that our agency needs based upon our structure, based upon our current composition of the workforce, and then secondly, based on our priorities of what the organization needs to carry out its functions, where are the greatest gaps? So what thoughts do you have on helping those agencies drill down further?
And can I just amend that question a little bit too, and just add, keeping this in the context of population health, if they were to get that, how would it help improve population health?
So a really short answer, because I know our time's limited here, is we do ask our health departments, and we're going to put more emphasis on this, to really think carefully about aligning their workforce development planning and implementation with their strategic plan, which we've also asked them to align, Phyllis, to your question, with their community health improvement plan. So if we could move that needle on the health department side, where whatever they in their community said needs to happen to improve the health status of that community, if that could be aligned with their strategic plans so that the implementation of those strategies are priority, and then the workforce is trained to do that. I mean, I know that sounds like a lot, but I think it's doable. We've seen some good examples of where that's happening.
Okay, we're going to move to the right, Mary Joan.
Good morning. Mary Joan Ladden. I'm a nurse practitioner, senior program officer at the Robert Wood Johnson Foundation. My question is really about preparation of health professionals writ large in terms of population health. We've been doing some work around population health preparation in nursing and about to expand it to all health professionals. So my question to the panel really is, how well is population health, the competencies and capabilities, integrated into accreditation standards and curricula across medicine, nursing, social work, all of the rest of the population health workforce that are health professionals?
So, I can only intelligently speak about public health specific training, but what I can point you to, there was some work done by the Association of Schools and Programs in Public Health called with their Framing the Future initiative called Health in All Professions. And there is a report, and I know it's on their website, and I'd be happy to point you to it at the break. But they convened a group of the other health professions to talk about population health infused in curricula. So I don't know if it was specifically about accreditation or not. The other thing that I know is that the Association of Specialized and Professional Accreditors is essentially the membership association for my counterparts in all the professions. So, and many of those are health professions. We worked several years ago on a task force on the professional doctorate. Among all of the health professions. And I will say that population health was one of the areas that was common actually in the professional doctorates. So I don't know at the master's level, but I do know at the doctoral level. I'm sorry, that's not very specific, but I wanted to point you to those two resources.
And I'm so sorry, we're at our time. but I'm sure the panelists will stay around to answer any other questions that still are remaining. Thank you all for your questions. Thank the panel for the wonderful presentation and response. I think we have for about 10 minutes.